Bismillah ar-Rahman ar-Rahim. Thank you very much for allowing me to participate in the 27th Congress of Romanian Society of Pneumology. My talk is about the imaging of lung cancer, and as you all know that this type of cancer is intimately related to cigarette smoking or the smoking in general. And we have different histologic types, including the small cell lung cancer and the non-small cell lung cancer and the undifferentiated lung cancer. The role of imaging is threefold. Number one is to characterize the primary lesion. Number two is to assess the relationship of the tumor to the pleura, the chest wall, mediastinum, and airways. Number three is to assess the distant spread of the tumor anywhere in the body. These are the most important radiographic signs for the diagnosis of bronchogenic carcinoma. Number one is the detection of peripheral pulmonary nodule with a speculated margin. Number two, enlarged dense hilar shadow. Number three is the detection of a solid pulmonary mass in an adult of whatever age and whatever CT density, either containing calcium or containing areas of breakdown. Also, a central lesion with ipsilateral diaphragmatic elevation due to phrenic nerve paralysis, consolidation collapse due to bronchial obstruction, especially in adults, then the presence of malignant pleural effusion as confirmed by cytology, and the S sign of Golden. This is an example of a speculated pulmonary nodule in the left lung, and this is an example of a mass in the right lower lung lobe, and this mass of course should be further evaluated by CT to assess that it is of solid nature and to see the edge and also the rest of the thoracic structures. And here is an example of central bronchogenic carcinoma with obliteration of the upper lobe bronchus, resulting in partial consolidation collapse of the upper lobe and displacement of the major fissure anteriorly. And here you can appreciate that the hilar shadow is enlarged and is relatively dense compared to the opposite side, with associated elevation of the ipsilateral diaphragm, which is highly suggestive of associated phrenic nerve paralysis. Sometimes, whenever you go to the CT, for many reasons, of course, for confirming the nature of the lesion, for staging of the tumor, for using it as a guiding tool to have a biopsy, then you can see that the lesion is almost solid with central area of breakdown. And here what is known as the gold, this is a sign of Golden, where you got a central mass associated with consolidation collapse of the upper lobe. And here is what is meant by the S sign. You see that the tumor mass and the edge of the collapsed upper lobe may form what looks like the letter S. Then characterization of the primary lesion depends on the imaging findings that are sometimes highly suggestive of the presence of malignancy, like, and if you can see here, this pulmonary nodule with a very characteristic speculated margin, and compared to this benign nodule with a smooth edge and central calcification. Then bronchogenic carcinoma will show a solid mass or nodule with a speculated margin of the nodule, may be also seen in the mass. Sometimes you got a relation to the bronchus, and you got what's known as pleural tails, and these are no more signs for supporting the diagnosis of bronchogenic carcinoma. If you see a pulmonary nodule, and these are the possibilities for the pulmonary nodules frequently seen in the clinical practice, including the tuberculoma, hamartoma, the bronchogenic carcinoma, the metastatic deposit, arteriovenous malformation, and the hydatid cyst. What's very important here is to differentiate or to assess the possibility of the nodule to be an arteriovenous malformation, because you know that the next step for radiological diagnosis of a bronchogenic carcinoma is to have a needle guided biopsy, and be careful not to attack such a lesion because of the major complications. A mass of whatever age and whatever density, like heterogeneous density, the presence of calcium, a mass, a solid mass in the lung of an adult should be considered as a bronchogenic carcinoma until proved otherwise. And this is a good example of a bronchogenic carcinoma in the right upper lobe. And you may see some of the speculated margin, which is not important in cases of masses. And this is an example of a bronchogenic carcinoma in the lower lobe, showing internal air loculus as well as some foci of calcification, and this is another case showing areas of breakdown. Sometimes you got central cavitation within the bronchogenic carcinoma, resulting in a cavity with a thick wall and a regular inner margin, and these two features are very important. This patient had a solid mass that was diagnosed as a bronchogenic carcinoma. He refused to do anything, and he came after 3 months for follow-up, and you got that the lesion has developed central cavitation with irregular thickening of the wall as well as irregular inner margin, characteristic of a cavitating bronchogenic carcinoma. Whenever you see a cavity in the lung and inside the cavity you got a mass, then the differential diagnosis will include the fungal ball, ruptured hydatid cyst, necrotic tumor, and the blood clots within a benign or malignant cavity. What's very important here is the wall thickness. And they got here a thick irregular wall and the extremely irregular inner margin. Then this cavity is malignant, whatever its content. It may contain air, it may contain air fluid level due to bleeding inside the cavity, it may contain a ball like this due to the necrotic shreds of the tumor forming what looks like a ball. And the presence of a ball and or air fluid level or both does not go to another pathology, but you should insist for that this cavity is malignant because of the thickness of the wall as well as the irregular inner margin. And this is another example of a cavitating bronchogenic carcinoma with irregular inner margin and internal air fluid level due to bleeding inside the cavity. And this is also another example by X-ray and CT. You got what looks like a soft tissue mass within the cavity, which is just a thickening, abnormal thickening of the wall, as well as air fluid level due to bleeding inside the cavity. Another example of breaking down in a bronchogenic carcinoma seen by X-ray and by CT, and you can appreciate the irregularity of the inner margin in this section. Then, in order to assess the relationship of the mass to the chest wall, it is not enough that the mass is in contact with the chest wall to suspect that the chest wall has been invaded. But there are two signs on the CT scan that are pathognomonic for chest wall invasion. Number one is the presence of rib destruction adjacent to the tumor, and number two, and you can see tumor tissue beyond the chest wall, I mean in the subcutaneous area. Then if you see a mass like this associated with destructed rib and the bulge of the tumor underneath the pectoralis major muscle, and you know that the chest wall has been invaded. And this is another example. And you can see here destruction of the rib and extension of the tumor outside the thorax. And the invasion of the chest wall in the early days was a contraindication for surgery, but now it is no more a contraindication for surgery. And also the MRI is more better for evaluation of a chest wall invasion, especially if the destructed rib is not that evident in the CT scan because of the signal difference between the tumor and the chest wall muscles. One of the tumors that is very important to have an MRI here is the Ebankus tumor or the superior sulcus tumor. And this tumor is easily diagnosed from the plain film by the presence of an apical mass associated with some destruction of the related ribs, and is also diagnosed easily by CT scan for the same criteria. But what is important here is to assess the relation of the tumor to the brachial plexus roots as well as to the subclavian artery and the vein. And this relationship cannot be achieved without MRI, especially in the sagittal image. And you can see here, this is the Bankus tumor, and this is the site of the brachial plexus, this is the subclavian artery, and this is the subclavian vein. Any invasion of one of these three structures will contraindicate surgery. Then in cases of a central pathology, you have to discriminate between the tumor mass and the associated consolidation, especially whenever you are going to have a CT-guided needle biopsy. In such conditions, you should go by the needle as deep as you can to attack the tumor tissue and not to have the biopsy from the consolidated lung. CT is less sensitive in discriminating the consolidated lung from the tumor tissue, but MRI, because of the different water contents between the tumor and consolidation, can see clearly, especially in the T2 weighted image, the difference between the lung consolidation and the tumor mass. Also, invasion of any of the mediastinal structures will contraindicate surgery, like invasion of the pulmonary artery or total encasement of one of the main pulmonary arteries. This will contraindicate surgery, and this is another example of a bronchogenic carcinoma totally encasing the left main pulmonary artery, which is markedly attenuated compared to the right side, associated with mediastinal lymphadenopathy. Invasion of the mediastinal fat does not contraindicate surgery, but invasion of the mediastinal structures will contraindicate surgery, like invasion of the superior vena cava, which is totally obliterated by this big tumor mass, invasion of the left atrium, where you can see the tumor is extending inside the left atrium. Of course, PET-CT has an important role in assessment of patients with bronchogenic carcinoma, but it has also some fallacies in this domain. They considered in the early days of PET-CT that a lesion with a standard uptake value of 2.5 may indicate malignancy, but this idea has been changed to consider that whenever the standard uptake value is more than 3.6, this may suggest that this nodule is malignant. But nowadays, you can see many fallacies in this domain. This is lesion associated with some atelectasis with significant uptake and has been proved to be a lung cancer. And this lesion with fat inside, diagnostic of a hamartoma, showed no significant uptake on the PET scan. This nodule in the right upper lobe is examined by PET-CT and showed significant uptake, but it has been proved to be a tuberculoma. These false negative or false positive results for PET-CT may be encountered in the clinical practice. Also, you see this patient who is immune compromised and he got a mass in the lung with a speculated margin, and this mass has proved to be a fungal infection. One of the values of PET scan is to separate the tumor tissue from the related consolidation because of the different metabolic activity in both, and also to show some of the metastatic lymph nodes that cannot be seen in the CT component of the PET CT because of many factors. Number one, absence of contrast injection, and number two, respiratory misregistration, and this will affect the results of PET-CT in many cases. And this is another example of a bronchogenic carcinoma attenuating in the right main bronchus, and PET-CT showed that this is the tumor mass and this is the related consolidation. Of course, the detection of lymph nodes in the mediastinum in patients with bronchogenic carcinoma will affect the prognosis of the tumor markedly. And you should know that about 13%, according to the literature, of normal-sized nodes may contain tumor tissue, while about 37% of nodes measuring from 2 to 4 centimeters may not be malignant. Then, on the basis of CT, detection of calcium in lymph nodes may indicate a benign nature. But if you use PET-CT, and you can see that this is the bronchogenic carcinoma, and these are the nodes. And this arrow points to a detected node on PET-CT, but it's not seen on its CT component because of the respiratory misregistration. And this is also a node better seen by PET-CT, not by CT, because of course of the absence of contrast injection. And these are what's known as reactive lymph nodes seen in the axilla as well as in the mediastinum, showing no significant metabolic activity. CT-guided or ultrasound-guided needle biopsy is one of the important procedures in the battery for evaluation of lung cancer. Of course, whenever you identify or suspect a lung cancer on the basis of X-ray and CT finding, I think that the better way or the best way is to go direct for needle biopsy. Then whenever you confirm the diagnosis and you know which type of bronchogenic carcinoma you are dealing with, then you may start to have the PET-CT to assess the metastatic, if any, deposits, and to judge if this patient is a candidate for surgery or not. And CT-guided needle biopsy is not without complications, and many times you can see some degree of pneumothorax in about 30% of the cases, but this is a limited pneumothorax and resolves spontaneously. And sometimes you got a rapidly accumulating pneumothorax in about 6% of the cases, especially if the patient had a chronic obstructive pulmonary airway disease, or the lesion is deep in the lung, or you perform in multiple trials to reach the site of the lesion. Also, if the coagulation profile is not suitable, and you have to go to biopsy a lesion like this one, which is posterior to the superior vena cava and also related to the pulmonary vasculature, and you go for a long distance in the lung, there is a big incidence that the patient will develop pulmonary hemorrhage. And this hemorrhage, the incidence of hemorrhage will increase if you use large caliber needles and the coagulation profile is not good. Thank you very much.